I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series, but I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsor, Novartis, for supporting these webinars. In today's webinar, we will hear from Professor Elizabeth Brower about some key points of interest from the 2025 Eular Congress, which is the European Alliance of Associations for Rheumatology. Before we get started, I'd like to introduce our guest today. Professor Elizabeth Brower, MD, PhD, is the leader in the Large Vessel Vasculitis GCA PMR research line, Vasculitis Expertise Center, and staff member in the Department of Rheumatology and Clinical Immunology at the University of Groningen, Netherlands. Welcome, Professor Brower. We're so happy to have you here with us today.
Thank you for your very kind introduction and happy to give a talk for the patients.
Great. And before we get started, we're about to share your slides, but before we get started, could you tell us if you have any disclosures today?
No closures regarding this presentation, no.
Okay, great. Well, then we're going to get started and you can educate us about what you learned at Eular anytime you're ready.
Yeah, thank you. Yeah, so I'm happy to share the Eular highlights from 2025, and I will focus on GCA PMR because in those diseases a lot is going on. Next slide, please. I'm working at the University Medical Center Groningen. Next slide, which is actually the largest employer in the northern part of the Netherlands. It's an economic engine, and we focus on healthy aging. So we really want healthy aging for all, including our patients. Next slide. Challenge one, I think, in GCA and PMR is good getting a right diagnosis. Next slide. Okay, so why did I include PMR? As you can see on this slide, already published in 2023, PMR is not always PMR. It overlaps with GCA, and that's why we call it GPSD, GCA PMR spectrum disease. But PMR, of course, can also mimic other rheumatology disorders. Next slide. So how do we diagnose patients? So we have classification criteria, and those are made by a combined effort of the Eular and the ACR. So for PMR, you need morning stiffness, pain in your shoulders and hips, and absence of rheumatoid factor. The same goes for GCA. Next slide, please. We also made classification criteria, but then there's morning stiffness, vision loss, jaw claudication, temporal headache, pain on your head, and what's coming up, what you can see in this slide, is that you really need lab imaging and biopsy criteria to be able to diagnose the patient. Next slide. What do we do in ultrasound? We are aware that arteries get thickened upon the disease, what you see in the upper slide. So there's really a thickening of the wall of the arteries, what we can see by ultrasound. So what's coming up is a halo count, so that you do an ultrasound of your temporal arteries, but also your axillary arteries, sum them up. You get a halo count, which is an estimate for the presence of giant cell arteritis. Next slide. So at the Eular 2025, there was a presentation by Juan Molina, and he showed data from the OGUS, which is the ultrasound score by the OMARACT, which is really an organization of rheumatologist collaboration worldwide. And also, he found that this combined ultrasound score of different vessels also has dynamics in the sense that once you start treatment, your vessel wall becomes thinner upon treatment, and you can do follow-up. So really, ultrasound is popping up not only for diagnosis, but also for follow-up of disease activity in giant cell arteritis. Next slide. It's even that there's in development of ultra-high frequency ultrasound, in which you really can see, and there was a nice poster on the Eular, in which you really can see the 3 layers of the large vessel wall, and you can really see anatomy via the ultrasound and see the different layers that they are increased when there's giant cell arteritis in a vessel. Next slide, please. So what would we do? This is my colleague Maria Sandovici. We made a scheme in which we say, okay, if you have a low suspicion of GCA, you can do one test, either ultrasound or PET scan. If it's negative, you can rule out giant cell arteritis. If you have intermediate suspicion of giant cell arteritis based on clinics and lab tests, then you should preferably do 2 tests. If cranial arteries involved, you can also perform a biopsy. But in line with the ACR Eular criteria, it's very important to get proof of vasculitis either by imaging or by taking a biopsy. Next slide. So this is a nice example of the PET scan. So also the PET scan, this is a PET vision, and we do dual time imaging. The PET scans become more and more faster and more detailed. In a way, you can really show your large arteries, aorta, branches, but also the vessels to your head. So also the PET scan can show your cranial arteries, whether they are involved or not. And in this patient, you typically see also uptake in the spine, which shows intraspinous bursitis, which really shows that this type of GCA is overlapping with PMR. Next slide. So this is a detail of your aorta, your branches to your arm, and you really can see it's positive, it's black, really showing large vessel vasculitis, giant cell arteritis. Next slide. And there's even the patient is moving, but you can go to the next slide. So there was a nice presentation by Meta Suwamber. This is a collaboration together with the patients. That's a Delphi exercise. How do we define disease activity in giant cell arteritis? And she nicely showed the items which came up on the Delphi exercise. And it's again a European-American collaboration, including also patients to get a right grip on disease activity in giant cell arteritis. Next slide. Prednisolone. So the second chapter goes about prednisolone. I think it's very important in vasculitis, but also giant cell arteritis and PMR to get to treat patients with prednisone, but with as short as possible and with a low dose possible. Next slide. So we know that we are aware that more than 90% of patients have, unfortunately, glucocorticoid side effects. Next slide. And they also impact quality of life. So this is Jannik van Sleen, and we show on the y-axis the score, on the x-axis the years, and really we see patients during treatment, they stay fatigued in comparison to healthy controls, both GCA and PMR, and the same goes for their global well-being. Next slide. So there was a nice presentation by Frank Boetkereit on the SELECT GCA study. This is the upadacitinib trial in giant cell arteritis. Upadacitinib is a JAK-STAT inhibitor, and the data from the trial were already presented at ACR 2024 by Daniel Blokmans, but Frank Boetkereit showed a nice sub-analysis. Next slide. And what became clear is that, and you can see the glucocorticoid taper. There was a placebo arm with glucocorticoids for 52 weeks, and then the short taper is the 26-week taper. And the next slide, what you can appreciate is that side effects are more present in the prednisolone treatment, in the long prednisone treatment arm, so especially the infectious complications. The only exception was the varicella zoster, herpes, This was more severe in the upadacitinib arm, and for this reason, patients are advised to get a Shingrix vaccination before start of upadacitinib treatment. But what you can appreciate that prednisolone long term is as worse as our DMARDs or even worse. Next slide. Treat to target. Then we can go to the next slide. Well, we're fortunate to have a lot of ongoing trials also in PMR. So there's methotrexate, leflunomide trial ongoing in the Netherlands, tocilizumab studies. I will show the data. There are completed trials, the sarilumab trial, which is approved for PMR in the US, not yet in Europe, and which was a positive trial, SAPHIR trial, presented at ACR last year. Rituximab trial, B-cell targeting, abatacept, baricitinib, tofacitinib, and also the secukinumab ongoing trial. I think the data will be presented maybe at the ACR this year or next year. Next slide. So a lot of studies going on. At Eular this year, Aatke van der Maas presented the methotrexate trial in PMR. And next slide, the trial was positive. So the proportion of patients in GC-free remission at 52 weeks was significantly higher in the methotrexate group compared to the placebo group. And the proportion of patients in GC-free remission was 80% versus 46% for methotrexate and placebo respectively. So there was a lower incidence of relapses also in methotrexate group. So this trial seems to be positive, but the data, the paper needs to come out. So be on the watch out for the paper. Next slide. Tocilizumab, I already told, IL-6 receptor blockade in PMR. Now we move to GCA. I think everyone is aware of the successful GIACTA trial, which was a worldwide trial on tocilizumab in GCA. Next slide. And there, the follow-up data are also positive. Next slide. What at the Eular were the follow-up of the TOPAZIA trial. So this is what's coming up, really short course of glucocorticoids, only 3 days, and then tocilizumab only in giant cell arteritis. This is the group of patients without eye involvement. So that's important to mention. Next slide. Sorry for the disturbance. Francesco Muratora, an Italian colleague, showed the data, the follow-up data in this TOPAZIA trial. And what they found is that despite treatment, he did a PET imaging follow-up, there's still vessel wall activity. And 10 events occurred, 7 relapses and 3 aortic dilatations in patients with large vessel GCA. So it's important also in follow-up not only to check the patient, the lab tests, but also keep an eye on your vessels. So that's the important message. And from TOPAZIA, we already know that probably you can give a short course of glucocorticoids and continue with IL-6 receptor blockade. Next slide. Tocilizumab, there's a debate, but also the same goes for glucocorticoids. Probably some patients have persistent wall inflammation. This was presented at the Eular last year. So we're still also myself, I'm an advocate for have a look at your vessels, not only at diagnosis, but also during follow-up of patients to check whether it's okay and whether the patient really goes into remission also on the vessel level. Next slide. The titAIN study, secukinumab in giant cell arteritis, this was a phase 2 study, so not phase 3, presented by Niels Venhoff at the Eular. And the next slide shows the data. The trial was positive, so in favor of secukinumab. But remind, it's a phase 2 trial, and unfortunately this did not make it into a phase 3 trial in GCA. But the results look promising, and the secukinumab trial phase 3 in PMR, the results will be there, I think, this year or next year. Next slide. Select GCA study, again from Gutgereit, already presented at the ACR last year. Also 26-week steroid taper, and upadacitinib was positive in this trial for GCA. The drawback, of course, of a JAK-STAT inhibition, upadacitinib, in patients over 60, there's a cardiovascular risk warning. So you should look at a group of patients in who you are going to treat, but the trial was positive. Next slide. So those were the data, really positive, the upadacitinib 50 milligrams and the 26-week glucocorticoid taper. Next slide. So DMARDs are coming up in GCA and PMR. This is a nice overview. I put also the references there. So I think there's hope for patients like in ANCA-associated vasculitis. DMARDs, non-biologicals, biologicals are really coming up. And luckily the prednisone courses become shorter and shorter. And we have a wealth of treatment, luckily, also for patients in vasculitis. Next slide. So session summary, it's important to have a good workup of PMR and GCA, rule out other diseases, include imaging. Imaging is key. Potential burden of long-term glucocorticoids, be aware, but I think both patients and doctors are very aware, unfortunately, of the side effects of glucocorticoids. Glucocorticoids are sticky. Once a patient is on glucocorticoids, it's very difficult to taper and to get to zero in a group of patients, and therefore it's very important to consider glucocorticoid sparing treatment early in the disease, or at least at the first relapse in GCA and PMR. Next slide. Thank you for your attention, and this is an overview of the vasculitis group at the UMCG.
Okay, thank you so much, Professor. That was a lot of information that you shared with us. I did basically get a takeaway of it appears that there are a lot of medications that are under study now, and also imaging things. Very, very interesting. But I wonder, do you have a general feeling or takeaway from key points that things that you think came out as a result of this Eular Congress?
Yes, I think really imaging, not only for diagnosis, but also for follow-up. And I think the short prednisone tapers, so that we really go from long-term treatment with glucocorticoids to really try to be within 26 weeks or even shorter. Short courses of glucocorticoids, and then continue with disease-modifying antirheumatic drugs, so with other drugs.
Okay, and there were a couple of terms that I'm not familiar with. So on behalf of patients, I'm going to ask these questions. One of them was in Dr. Suwamber's presentation, you said it was, I think you said it was a Delphi exercise. I don't know that term. Could you tell me what that is?
That's a kind of, you can look it up. It's a kind of structure to get evidence for data. So what data should we look at? You go first into literature, then you make questionnaires. Questionnaires are sent to patients as well as to doctors, different group of doctors, and then together you select items which are important for patients and doctors and who can reflect disease activity. So it's a kind of stringent procedure to get the right items to measure disease activity.
Okay, that does make sense. She did a presentation with us also, and I did love her chart. So it made it easy as a patient for me to understand.
It's a kind of chart which you follow in order to get the best evidence, but also from patients and treating physicians.
It's slightly different probably, but so Professor Brouwer, we just would like to know your thoughts on anything major things that you learned from Eular. For instance, we've heard a bit about precision medicine. We've heard a bit about AI. directed ultrasounds, things like that. So if you have any thoughts on that, we would love to hear what you took away from Eular.
Yeah. So precision medicine indeed is about AI. You have a lot of data from ultrasound, from biomarkers, from patient characteristics, clinical data, and you make a kind of profile of the patient to predict what's the best treatment for this patient at this moment. So that's what it is about. So from ultrasound, what I showed, and also the PET study presented by Muratore, it's about more detailed analysis of your images. So you get a lot of data, and from that data you build a profile. And AI is really helping us with not only saying, okay, the scan is positive or negative, but much more detailed data you can get from those scans. Yeah, and that's where AI is helping us.
Okay, great. Thank you so much. And I just want to share my screen here as I say thank you so much for taking your time to educate us today, Professor Brower. We would love to thank the Vasculitis Foundation and our sponsor, Novartis, for their commitment to patient education through these medical webinars.